So the hosts for today are myself, Peter Yanevsky, Strategic Communications Associate at Histiocytosis Association. We're a nonprofit organization dedicated to raising awareness about histiocytic disorders, providing educational and emotional support, and funding research for better treatments and the cure. Sarah Rusch is a physician's assistant physician assistant manager at patient services NMDP. She earned her master's in science and physician assistant studies in Rosalind Franklin University of Medicine and Science in 2007, and has spent her career focused on pediatric medicine. A number of years spent on the University of Minnesota doing pediatric blood and marrow transplant care. She has been with NMDP since July of 2022, managing their clinical services team, which is composed of their survivorship program, and PACES, which is patient and caregiver emotional support program. And finally, was that Vigiera, the senior director of education and support at the Leukemia and Lymphoma Society. She oversees the national patient education offerings for LLS. These multimedia patient education programs include patient webcasts, such as this one, virtual lectures, videos, chats online, podcasts, to provide blood cancer patients and caregivers with up-to-date information and support. So with that, we're going to start with our first of two patient stories. Pardon me. David Stein is going to be the first of those two. He is a T-cell acute lymphoblastic leukemia survivor with a bit of an odd story of a transition care. Let me take it from here, David.
Yeah, how you guys doing? As Peter said, thanks, Peter. Thanks for having me. I'm David. My story is a little bit unique. So I was 20 years old when I got diagnosed, which is obviously right on the cusp of adult and pediatric care. And because I was an adult, I don't really think that my family and I put as much thought into it as we didn't like research the pros and cons of pediatric versus adult care. I was an adult, so we just went into the adult hospital. Where I'm from, there's a very reputable hospital, so we just kind of flew into that. My care initially, my original treatment, I got into remission, and there was a few hiccups, but for the most part, it was relatively smooth. But I relapsed very quickly, and so when I went back to the hospital, we kind of my family and I came up with some complications with that hospital, because just the way that it worked was I was an inpatient, and this doctor wanted to do some things for my care. He was the person who was on service when I was an inpatient. And my actual oncologist, who was the manager of my care, she didn't agree with this treatment. And it was pretty serious. And it was one of those, my family and my oncologist didn't agree with it. But the way the hospital worked was whoever was running the floor that day, they were in charge of your care. And my family and I just fundamentally didn't agree with that. And my father kind of had issues with them even going back to before. So this was kind of like a breaking point. So what we ended up doing is we ended up researching, and there's this hospital in Cincinnati, Ohio, which is not too far from where I'm from, called Cincinnati Children's Medical Center. And they were actually #1 in the country in young adult cancer care. So that's 18 to 30. So I was now 21, and, so obviously I fit that window. So I actually went from an adult hospital at 20 to a pediatric hospital, technically, when I was 21. And that's where I completed my treatment. So I had a bone marrow transplant in Cincinnati, actually relapsed again, and then had to undergo some pretty serious treatment that you wouldn't normally try because the circumstances were pretty dire. It worked. I've now been in remission for 11 years. But this treatment actually paralyzed me from the waist down for about 2 months. Now, at the time when I was paralyzed, we didn't know that it was only going to be 2 months. We didn't really know. So we were kind of in uncharted territory because the treatment that ultimately put me in remission was made up specifically for me. And then we actually tried another treatment that was specifically made up for me to reverse the side effects that caused my temporary paralysis. So, all that to say, and that's kind of the Cliff Notes version, but it's as I've kind of both during and as I've been removed from it, as I'm sure a lot of other patients can relate, when you have cancer, you kind of touch a lot of different disciplines, right? Like obviously, your oncologist is the person who runs everything, but because of side effects, because of whatever, you end up kind of getting the full patient care experience. And I noticed personally some pretty big differences between adult and pediatric care. As I kind of alluded to, one of the things that my family and I struggle with was there was a lot of ego on the adult side. And that's, you know, the hospital that I was at was a very kind of hotshot, high rated adult hospital. And that ego kind of brushed up against my father and myself a lot. And we didn't experience that as much in the pediatric world. And what's important is, you know, obviously the doctors are the medical experts, right? I would never challenge them on that. But when you have cancer and as you spend more time touching all the disciplines and talking with more doctors, you kind of become an expert from the patient side, right? And so if something, doesn't feel right, or if something you feel like isn't explained to you uh, adequately, it's really important that to not just advocate for yourself, but you're the boss. And I think that was one of the issues that I had with some of the adult doctors was it was like this weird hierarchy of I'm the boss, which I just kind of didn't appreciate necessarily from the patient side. And listen, I'm not trying to disparage adult care. It was just my own personal experience with it, and that's kind of why we ended up going the way that I did. Um, but yeah, so that would just kind of be my takeaway with all these transitions. And then even as you get further away, you know, with all these cancer cases, you can't really know your full experience by simply reading your chart. So to all the people on this call who are transitioning the other way from pediatric to adult care, I'm not trying to scare you, sorry. Um, but you know your story better than anyone reading a chart could possibly know, right? And so your voice is just so critically important. And it's very, very important to remember that. So, you know, again, when someone's talking to you about your care, if you feel even slightly that they're not quite understanding or that something's a little bit off, I would say it's very important to just make sure that it's clear that you're in control, right? And you know the story better than anybody. And it's all about how you feel, especially as you move, transferring care and stuff like that. The only person who's there for everything is you, the patient, right? And that is just it's so critically important. And so I guess to kind of wrap everything up, that's what I would say more than anything is that it's a collaborative team effort, and you don't want to necessarily think of it as that sort of hierarchy, but the most important person obviously is you, the patient. And so when you're doing these transitions, whether it be from adult to pediatric, or from I saw someone mention in the chat from your oncologist back to your primary care, it's just kind of that same thing that there is a quarterback, to use a sports analogy. It's you. Um, and yeah, so I just wanted to say thanks for having me. Um, you know, I'm a pretty experienced patient. If you add up all the days I was an inpatient, it's almost a year and a half over the course of, my cancer care was supposed to be 6 months, and it ended up taking about 7.5 years. So in and out of the hospital, my longest stretch as an inpatient was for almost 7 months. So, you know, it's obviously not something that I was planning on, but it's something that I'm very proud of, and I feel to be as experienced of a patient as I am is a badge of honor in a lot of ways. And strangely enough, that the way that I ended up here is because one of my best friends, who's my age, his 5-year-old son a couple years ago, 2 years ago, ended up getting diagnosed with the exact same kind of cancer that I had. And so just talking to him throughout the process, as I'm sure many of you will realize as you get a little bit further away from it, is that you have a wealth of knowledge through your experience that can be so beneficial to people coming up behind you. And certainly it's something to keep in mind, is that obviously this is not something that you were hoping for, but it can be used for positives. It can be used to help other people. And so just thanks so much for having me. And at the end of all this, if anybody has any questions about transition or my care or the Cleveland Browns who lost this weekend, that's where I'm from, whatever you guys want to ask me about, I'd be here to help. Thank you. And I'll send it back to Peter.
Thank you so much, David. Sorry, Browns. I just want to introduce to you all Nate Milam, who is a hemophagocytic lymphohistiocytosis survivor. You may have heard of them more commonly. HLH, and is also a blood disorder that requires bone marrow transplant. It's a form of histiocytosis, which is the type of disorders that we represent. I'm personally working with Nate a lot in patient advocacy, which is something he's been very passionate about since surviving this ordeal and continuing to battle with this ordeal, which is one of the reasons that we decided to put on this webinar, is because I've been advocating for so many others that have this issue and continuing to fight some things himself. I'm going to let Nate tell a story and tell you more about the fight that he's fighting for this.
Hello, everyone. As Peter mentioned, my name is Nate Milam. I'm very thankful for this platform, and I appreciate everyone for attending because I have a lot to say. I'm not going to say it all in this webinar because we don't have a lot of time, but I'm happy to connect with people anytime after this, or if you have any questions. I was diagnosed with hemophagocytic lymphohistiocytosis. As Peter mentioned, that is HLH for short, because it's a mouthful to say. But before this diagnosis, I had a long journey as a PEDS patient. I would say mostly all of my journey happened while I was a pediatric patient. I was first misdiagnosed with Crohn's disease when I was 7 years old. I soon started treatment. I had infusions and injections, a multitude of things that were tried, but ultimately failed because my body developed antibodies to the medication. I was 19 when I was diagnosed with HLH after a long bout of sepsis. I was hospitalized in the pediatric ICU due to a failed bowel obstruction reversal surgery. My body just could not fight back the infection. So for those of you who do not know, HLH is a blood disorder that attacks your lymphocytes. My doctor likes to refer to it as a gas pedal with no brakes, because when there's an infectious trigger, your body sends out these fighters to fight the bad infections or bacteria in your body. And once they finish fighting, there's no control switch or process that turns it off. So it keeps on fighting, and then it starts targeting your organs. So I was under attack, And you can see here, the first photo all the way to the left is the peak of it. That was when I was in the ICU. I was in that state for a couple months. And when I woke up and they were scrambling to figure out why this kid with a severe case of Crohn's was having this body reaction, they drew conclusions, and actually they sent out testing, genetic testing, to the lab in Cincinnati where David had gone to, and they discovered that I had positive matches for HLH. So the only treatment that they know of right now to cure it is a bone marrow transplant, which this is my journey. These photos from left to right is actually my journey in that order. So my first steps, like with physical therapy after being bedridden, the chemo that I had to go through and losing my hair. And then finally, the top right photo is my transplant day. It actually happened like really early in the morning, around 12 a.m. It's 5 years this month. So I'm very happy to be alive and get to share my story with you all. But one thing that I did want to draw attention to was the fact that I was misdiagnosed with Crohn's 3 different times. So the genetic mutation that I had at birth is called XIAP. It affects, I don't know if, I think it's mostly men, because it's an X-linked genetic trait. So it presents itself in 3 different ways. One affects your lymph nodes, another one is HLH, and the third is IBD. So with that knowledge and the outline of how my disease presented itself as a young kid, the first obvious sign that they saw was IBD. They did the testing and they concluded Crohn's disease. My physician told me that 2 key markers of why it's not Crohn's and it is something more is that it was diagnosed so young and that I wasn't responding to any of the normal Crohn's treatment. Most Crohn's patients can take medicine and find remission, but I fought for from 7 to 19 without finding that remission. I've had 13 surgeries in 14 years. I don't have a colon anymore. I've had 2 ostomy bags attached to my chest. I've had to readjust my entire life because no one at the time had the knowledge of what this disease was. I've been to a few GI doctors, none of which had heard of HLH before. So when I was diagnosed with HLH and I had the treatment and I survived the experimental transplant that isn't super successful in a lot of people, the care team in which I was on in the hospital that I went to, they changed the way they diagnose Crohn's patients. They now go a step further and automatically send testing to kind of eliminate that as a factor. If it looks like he has Crohn's, he may have this other thing. Let's just be sure. That wasn't available for me at the time, so I went through this crazy experience, and unfortunately, it was rough. But I just graduated with a degree in health services management because my dream and my goal is to spread awareness. And as Peter was saying, I've been advocating for this for a long time. Before I knew it was HLH, I was advocating for better treatment in hospitals as a Crohn's patient. But I know we're here to talk about transition of care. So I went from peds to adults, and I had to see adult providers after my transplant. So I was 19 when I had my transplant. That's, some hospitals have different policies where you can stay longer. But I did have to seek out a primary care that was an adult primary care. And it was not easy. I didn't realize how difficult the process would be to just find someone who could take on more patients, let alone one who was equipped to kind of handle or understand the journey that I had been through. So I found one who basically told me, I know you've been through a lot, and I'm here to learn because I don't know much about it myself, but I can coordinate with any doctor, I can refer you to anyone, and I can write any script that you need me to write. I'll just be here as a supplemental hand because I don't have the knowledge or the experience. And although that may sound a bit worrisome, if you compare it to what I have faced amongst other providers through this whole experience, most of them I realized are afraid to say, I don't know, or are afraid to not have an answer. So instead, they keep fighting and telling you things as if, like David was saying, they're in control. One thing I had to break out of was the fact that as a patient, you are in control. There will not be any doctors without patients. So once I grasped the fact that I can take my care into my own hands, I can refuse treatment, I can go to a different hospital, I can say no. I have a right to know my information, and I have a right to not do what I want to do with my body. Once I broke through that barrier and started seeing physicians as people, and like, what can you bring me or do best for me, that that's in my best interest, I realized what I needed in a physician. And the ones that I were going to, um they were very much so, in a way, in a lack of better words, power hungry, because they just, I'm the doctor, this is what you need to do, what I recommend, and this is how it's going to be. So I had a brief stint in the hospital after my transplant. I was on the adult side for the first time ever, and it was like hitting the refresh button. I was on the adult side. They didn't know who I was. They didn't know my preferences. And when I would try to explain to them that I knew more about my condition than they did, it was like talking to a wall. Like, they went through one ear and out the other, because we're the doctors in charge, and we know we have resources. We'll just go research it and we'll talk to these people. But why aren't you talking to me? So I realized that the primary care physician that I found was great, because he was, I don't want to say brave, because it shouldn't really matter, but he was willing to say that I don't know, and willing to say that he didn't have all the answers, but I already was taken care of by a bone marrow transplant team, an oncology team. You can't go to a patient first and expect them to treat you because they just know everything. We've been through this process and had this care team, so they can't do all of the basic things outside of your transplant case, but that's why you have a team of doctors who can collaborate with each other. I'm speaking a long time. All that to say, because I'm going on a little bit of a tangent, uh, it was a long journey, and we started at one place at one point in time where there was almost no knowledge about HLH. And I know my condition, out of all the histocytic conditions that we represent, or that are existing, it's not rare. HLH isn't rare. It's actually an orphan disease, compared to the other ones. So there is knowledge out there, but it's not being accessed. The fact that none of my GI doctors knew about HLH before is worrisome. Now they do, and it took my journey to educate them, but I'm trying to prevent more people from living the life that I did, from having to experience that. I'm trying to allow other physicians to know about this process and make change. I used to say this about Crohn's when I had it, that at first when I would talk about it, no one knew what it was. No one kind of understood the body system of Crohn's disease. And now I see commercials that are dedicated to preventing it or like to treating it. I see medical like prescription commercials that are like designed to, or dedicated to treating Crohn's and ulcerative colitis and things like that. So there is a way forward, and I'm happy to be speaking in front of people like this to help push that forward. So thank you all. I'm sorry for that. A long speech.
So without further ado, I just want to pass things on to Sarah Rusch. She's a manager in patient services, NMDP.
So as Peter said, and as both Nate and David had shared with us, we're talking about bridging a gap in the bone marrow transplant care. Specifically that gap that's transitioning our patients from pediatric to adult care, or for David's case, from adult care back to pediatrics and then back to adult again. As a quick introduction, my name is Sara Rusch. I'm a physician assistant. I currently work at NMDP in patient services. Specifically, I work within our clinical services teams, which is comprised of a survivorship program, as well as a PACES program. I'm in my 16th year of practice, and I've spent the bulk of my career in pediatric medicine. I thought I'd share with you a few of the fun snaps in the spaces that I've had the opportunities to work over the years. This top photo is of me when I'm working in primary care pediatrics and showing off one of the many perks that comes with pediatric medicine, and that is that costumes are welcomed and expected if you are working in pediatrics. So this was our team, and we were dressed up as Toy Story characters, obviously, and I am the short one in the middle, Mrs. Potato Head. And then the photo below that is a sweet baby that I had the opportunity to care for while I was in Guatemala, doing a missions trip down there, taking care of pediatric patients. Doing primary care medicine for them with acute, intermittent acute procedures as they were needed, but primarily it was primary care, well checks for those individuals. And then the photo on the right is the bone marrow transplant team that I had worked with at the University of Minnesota. We were performing a bone marrow harvest on that particular day, and that was on a young man, and that harvest was collected and it was infused into his younger sibling later on that afternoon. So I'm sharing these with you just to show that I've had the opportunity to really work in a variety of different pediatric settings, as well as the transplant space for many years. And I've really had some great opportunities to see some of these transitions go smoothly. And I've seen some of them go not quite so smooth and have some hiccups along the way. Just for housekeeping disclosures, I have no disclosures to share. The thoughts, the recommendations that I'm providing throughout this presentation, really they're coming from my own experiences collected over the years of working with a variety of different patient populations. So, bridging a gap in transplant care. There are countless opportunities to improve upon when it comes to the care of our patients. The opportunity that I really want to focus on today is the handoff or the transition of our pediatric patients as they graduate to adult care teams. The treatments of blood disorders that require transplant, they've come a long way, leading to improved outcomes and increased survival rates of our patients. However, an area where patients continue to struggle is what we've been speaking of today, and that's making that transition from one care team to the other. Transitioning from a pediatric to adult care team is a significant step for a patient, in particular those with chronic conditions or those with ongoing medical needs. With the continued evolvement and advancements of transplant medicine comes more and more success stories for our patients. This also means that our pediatric patients are thriving into adulthood, and that transition from pediatric care to adult care is needing to happen. I like to showcase this graph at any opportunity that I can. So some of you have probably seen this before. But these two graphs, they're showing us trends in survival after allotransplant for a diagnosis of AML, which is the most common indication for transplant. This study collected data from 2001 to 2019, and it monitored the survival probabilities over a 5-year course. The probability of survival, it leaped from 50 to 70% in our under 18-year-old population. And it shows a similar trajectory for our patients 18 years of age and older. Our patients are thriving into adulthood, and that is a beautiful thing. I have to note, it's not just our transplant patients that this scenario relates to. Numerous congenital diagnoses and chronic conditions are being detected earlier and earlier, allowing them to be properly diagnosed and brought to treatment in a far more timely fashion. With various metabolic diagnoses now being added to newborn screens, physicians and families can monitor those children closely, and they can make a calculated decision on when the timing is right for transplant or other intervention. It's a beautiful problem to have, to see these children flourish into adulthood. With that success comes challenges and sometimes a complicated transition of care, which our guest speakers have both alluded to already. So what is it that complicates this transition from pediatric care to adult care? It's really a multitude of different things, and by no means is this list exhaustive. But it does speak to the common themes that patients and parents share out, and a lot of these David and Nate have both spoke to already. The change in familiarity. It's a sense of community. Our pediatric patients, they often become accustomed to the familiar environment, routines, and relationships within the pediatric healthcare setting. They've developed trust and a sense of confidence in their surroundings. They know who and what to expect along the way. Transitioning to adult care means navigating a new and unfamiliar healthcare system, which can be intimidating, which I believe were exact words that David used. There's a loss of your pediatric support system. The pediatric care team, it involves a really close-knit support system. It's inclusive of your parents, your caregivers, the healthcare providers, child and family life specialists, music therapists, pediatric trained nurses, lab technicians, just to name a few. These individuals are all attuned to the specific needs of a child, and moving to adult care might mean leaving behind this supportive network, leading to concerns about the level of support in your new setting. It's often described as losing your security net or your security blanket. There's a level of comfort that comes along with those zoo animals that are on the walls. A commonality that comes, of course, with aging is increased responsibility, and that's not unique to medicine or to transplant. Developing responsibility as we get older is just part of life, but our patients, they need to take a more active role in managing their health, in scheduling their appointments, and understanding the complex medical information that is theirs. The shift in responsibility can certainly be overwhelming, particularly when a patient has been accustomed to more parental involvement in their care. Next on there is that patients will worry about the continuity of care and the quality of care during the transition, the fear of gaps in medical information transfer, changes in treatment plans, the potential for misunderstandings with new providers. All these things can contribute to or worsen what already exists for their anxiety levels. Furthermore, transitioning during critical health periods or critical global health periods like the recent pandemic. For individuals with chronic conditions and complex medical histories, the transition to adult care can coincide with critical phases of their health management. This adds an extra layer of stress as patients might be concerned about the disruptions to their ongoing treatments and plans. The psychosocial and emotional impact. Our pediatric care addresses not only the physical health of our patients, but it addresses their psychosocial and emotional needs. When a child is demonstrating a heightened level of fear and anxiety, people instinctively pause. They might bring in a toy, a coloring book, a child family life specialist if they're available. Children's emotions are acknowledged and addressed in every visit, every step of the way. Transitioning to adult care may raise concern about the availability of similar emotional support in that new setting. And of course, the fear of the unknown is a huge factor. The uncertainty of what to expect in the adult healthcare environment can contribute to fears and anxieties here as well. Patients are going to worry about how their needs will be met, whether they'll be heard or just talked to, as both of our guests have shared, and if they're going to receive that same level of personalized care that they experience in the pediatric setting. Which then leads me to the apprehension of the adult healthcare system. The adult healthcare system operates differently from pediatric care, as we've already highlighted in a multitude of ways. And I want to emphasize no one system is better than the other. They're just different from one another, and that patients simply feel uneasy about adapting to some of these differences. So how can we make this transition of care seamless and less scary for our patients? Addressing the fears requires a collaborative and supportive approach involving pediatric and adult healthcare providers, patients, and their families. Providing information, facilitating gradual transitions, and ensuring open communication can help alleviate some of these concerns and ideally promote a smoother transition. Other recommendations for this transition: early planning. Start planning for this transition well in advance. Work closely with the pediatric healthcare team to understand the steps that are involved and create a transition plan or a structure that considers the patient's specific needs and the patient's concerns. Ask questions. If nothing else, ask questions, and ask a lot of them. What age is the patient going to have to transition? What is the cutoff? This answer is going to be different from one system to the next. It's going to be different in the clinical setting as it is in the hospital setting. So find out what age your pediatric specialty team uses, as that data is really important. Ask if there's an adult provider within the same healthcare system or in the same building even, as that's going to make the transfer of medical records seamless. Ask for recommendations, ask for the opportunity to speak with them, ask friends that you've met along the way in your transplant journey or your medical journey. Get the input from as many people as you can, and it's okay to shop around. And as Nate said too, it's okay to say no. Inquire if the patient is going to require any kind of hospital admissions. What hospital do they go to? Should they go back to the children's hospital that they were at previously? Do they go to the local county hospital? Is there a specialty hospital nearby that's preferred? Finding out those answers would be important so that when you're in a time of crisis, it doesn't add additional stress to your plate. These similar questions will apply to the specialists that the patients are following with as well. Your pulmonology team, cardiology, endocrinology, neurology. Inquire about PT, OT, and speech if these things are needed as well. Emphasis should also be placed on the need to address behavioral health concerns before the transition even begins. Your mental health services and support across the transition should be identified early in the planning process to ensure there are no gaps in care and to be available for support throughout the transition if it's needing. Partnering with your social worker is strongly recommended, which kind of dovetails me into my next point. And that's your healthcare team involvement. You want to ensure that both the pediatric and the adult healthcare teams are actively involved in this transition process, as well as your social worker if it's desired. This collaboration helps in the seamless transfer of your medical records, any information, and for a smooth transition of care. You can even request at this point to have the two teams set up a phone call or a video call to have an intentional conversation about the patient's care. That is one silver lining that's come out of the pandemic, is that we've all learned how to utilize various platforms for virtual meetings, just like we're doing right now. It gives care teams the opportunity to ask questions directly to one another and to gain a better understanding of the patient before they arrive on their doorstep. And I can share with you personally that I've done this a multitude of times. I've done it from many different settings. As a provider in a primary pediatric setting, I've had numerous specialists reach out and set up video conferences so that they can give an intentional handoff of their patient. I've done it from the transplant setting and handing off a patient to the adult care team or even back to their primary care oncologist or primary care provider. But setting up video conferencing is really a lot easier now than what it ever was in the past. And so I strongly encourage doing that, if not just a phone call, to have that intentional conversation to make a good handoff. Which of course takes us right into the similar lines of that concept, and that's open communication. Encourage the communication and foster it. Request for the teams to exchange contact information, note the preferred times and the preferred forms of communication so that they have clear expectations with one another. If you utilize a care plan, this is a great space that you can write in that content information as well. So what is a care plan? Care plans are like a user manual specific to your diagnosis or specific to you as a patient. They'll routinely contain specifics of your diagnosis, your treatment course, your medications, your complication history, along with any recommendations for any routine screenings and preventative care. And as I alluded to previously, this is a great space to keep record of care teams and contact information. Self-advocacy skills. This is one I always enjoyed working toward in the pediatric setting. I love teaching and educating our young people and empowering them to advocate for themselves. Teach these patients about their medical history, about their medications, and any specific needs they might have. This knowledge empowers them to communicate effectively with their new adult healthcare team, as well as adults in general. Help them to understand their medical condition, allow them to actively participate in decisions, and show them how to navigate the systems. Most pediatric practices will start offering independent visits to their patients at the age of 12. To some families, that announcement is very startling. But if it's a routine visit or big changes and concerns are not anticipated, I encourage parents to allow their child those opportunities to take the reins on the visit. This could be with or without a parent in the room, depending on your level of comfort and, of course, depending upon developmental appropriateness. And these skills can be worked on in the home too. It allows for the patients to have the opportunity to really take the lead when it's appropriate. Along those same lines of learning comes the important discussions of insurance, finances, and benefits. I strongly recommend helping patients better understand their health insurance coverage and any changes that might occur during their transition of care. Provide guidance on how to navigate insurance and financial aspects of the adult healthcare system. These life skills are so important. And I really want to emphasize too that if the patient is going to require assistance with healthcare decisions into their adulthood, legal plans for this must be put in place by the age of 18 in most states. So caregivers should be proactive to obtain information about privacy and consent if this need is anticipated for the patient. Becoming an adult means learning about all the complicated adult things. And all of these are part of that. These topics can be challenging, but there are so many resources available to lighten the burden. Insurance companies will often make themselves available to provide education. Individuals within your own HR department of your work or your clinic are options to explore, as well as us. NMDP is available to help navigate these questions and inquiries as well. I know I've just given you a lot of words and information, ideas and recommendations to digest, but if there is anything that I can leave you with, it's to take a proactive and collaborative approach to this experience. The transition from pediatric to adult care can be a seamless process supporting the overall well-being of the patient if you plan early, if you communicate often and effectively, if you involve all the key players, empower our patients, and utilize a disease-specific care plan. Support systems are in place, and NMDP is eager to take this journey with you and your family. Our survivorship program offers patient navigation as well as opportunities to connect with our advanced practice providers who can assist you in this transitional journey and help to navigate the medical systems. In addition, they're available to guide you through your post-transplant experience, helping you along the way with access to educational resources and opportunities, navigating post-transplant complications, and they can connect you to financial assistance and grant opportunities amongst many other resources. Our PACES program offers Spanish and English-speaking social workers to provide emotional support to both the patient and their caregiver. They can help to develop coping strategies, help adjust to challenges that arise along the way, assist in finding reliable mental health related information and community resources specific to your family's needs, and so much more. I will leave our contact information available, and I would strongly encourage you to reach out with any questions you might have, as we are here, and as I said, we're eager to support eager to support you in your journey. I think I'm taking us up pretty close to time, so I'll thank you for your listening. And I will swap screens over and open things up to Q&A.
Thank you so much, Sarah. So if there's any questions, please pop them in the Q&A or the chat for us to read out. So there's one here already. It says, so this is partially for patients, but I'm sure they would love your advice on it too, Sarah. So the question from Jan is, was anyone else nervous about transitioning from their oncologist back to their regular doctor when in remission?
I can actually talk about that a little bit myself. So as it sounds like talking with Nate as well, my case was also pretty complicated. So, my oncologist during my real treatment, which was like 7 years, my oncologist was basically my doctor for everything, right? Because any kind of medical thing I needed from any other discipline basically would check with my oncologist to make sure everything was okay. So when I got into a more stable remission and I kind of transferred back to, I was also a new primary care doctor. As Nate kind of talked about, it's complicated because the person doesn't know you. And also, just to be frank, the the general care doctor is not an expert in oncology, an expert in these kind of these disciplines that require a little bit more knowledge and attention. So I think it just kind of, to feel nervous is, you know, totally normal because it's overwhelming for you, the patient. But as Nate kind of alluded to, I think sometimes it's even a little bit overwhelming for the primary care doctor because it's big. It's a lot more complicated than most of the reasons why people go to see a primary care doctor. So I think it's just kind of what Nate alluded to and what Sarah's talking about. Just that open communication between you and your doctor, finding someone who you're comfortable with. Obviously, that's step one. Someone who's willing to listen, and just making sure that you're on the same page, making sure that anything you feel, even if you bring it up and the primary care doctor kind of talks you down, explains to you, and it ends up not dismissing, but ends up talking you through something. If you feel uncomfortable, just say something. If you have a question about something, just say something. But yeah, it's definitely challenging at times making that transition for all the reasons that we've been kind of talking about. It's that first of all, it's a new person. It's a new person who wasn't there for so much of the highlights, if you will, or the lowlights of the care. But yeah, it absolutely was something that I struggled with when I did it. It was, particularly when you start talking about transitioning, not just from, pediatric to adult or vice versa, but when you're just finding that new primary care doctor and your chart has 7 pages to it or whatever. It's a lot for that person to take on. And I think, just that open communication is the biggest way. But as daunting as it can be, it's going to be okay. I know that sounds very just sort of Sesame Street, happy-go-lucky. But honestly, I think as long as you're open about what you're feeling and you feel comfortable talking to that doctor, I think you guys really can push forward through it, and you will get over that hump of anxiety or whatever. It'll go away pretty quickly once you start actively talking with that new doctor.
Sarah?
I'm looking at this next question that just came in. How do you keep the doctor in charge of a transitional rehab facility from changing the care plan set up by your previous doctor? That is, that's a really great question. Something I think we all kind of alluded to in these discussions of that fear that your care plan is not going to be followed. Ultimately, my thoughts and advice on this is that if you are finding yourself in a new setting with a physician who is choosing to make a strong right turn and deviate and go in a route that is not what was already laid out by your treatment team, that's a space for you to pause. That's a space to step back, touch base with your primary transplant physician, and run that past them, and make certain that they're in agreement with this deviation from the plan you set up. And if it's not something that is on board with what your transplant team has identified and created, then it's time to step back again and look for a different team, because you don't want somebody who's going to come in and try to recreate the wheel after you've already been through the thick of things and you're on the other end of it. you are supposed to be smooth sailing at this point, and you're supposed to be at a point where we're on kind of cruise control. And if somebody's choosing to make a lot of changes to the treatment plan that you've worked really hard to establish, that would be putting up a yellow flag to me. And it says that you need to have a couple more conversations.
Are there any other questions at this time? Please send them in. If there are other questions you have afterwards, please send them to some of the emails I'm gonna list here at the end. I'll just so we don't go over time, I'm gonna start going through just some of the resources that are offered by us and LLS. If you want to hear more information about osteocytosis and the Histiocytosis Association, there's our website, histio.org. There you can find disease information, educational videos, grant and research initiatives, the physician directory, which is international, the student scholarship program, which is going to start accepting some new applications late this winter, so look out for that. There's awareness toolkits, peer-to-peer connections. Follow our Facebook, and you'd also see there are some community forums that you can participate in. Or someone that has histiocytosis, or is a family or friend of someone with histiocytosis, to reach out there and get more in contact with the community. And then here are some support information from LLS. I'm gonna let Lizette take this one.
Yes, thank you so much. We do have information specialists that can assist you. You can call us or you can chat online or email us. We also have a clinical trial support center to provide you with information about clinical trials, as well as free nutrition consults that we do provide with our registered dietitians. And that service is available for any type of cancer, as well as for caregivers of cancer patients. These are other offerings from LLS. We do have a lot of support services as well as free education programs. So I do urge you to get onto lls.org for more of our programming. And just to let you know, we do have free information, and you can get that at lls.org/booklets, as well as information to assist with your finances. Thank you, Peter.
Thank you, Lizette. And I just want to remind everybody to take the survey that'll follow the webinar, yeah, just so we can get more information how you felt about this to improve future webinars on this topic and others. And there was a quick question that came in the chat, by the way, Sarah, before we show some of the contact. I'm going to put some of the contact information on the screen now, but some people can reach out if they want to. But she said, could we have more information for how to orchestrate the connection between the BMT team and handoff primary care doctor? I think some of this is a question for now, and some of it is also a request for future webinar topics.
Yeah, I'm reading through this, and
Yeah, okay.
I copied and pasted this one down so that I could answer it intentionally. But I know we're past time, but I'll take a couple seconds really quick just to kind of hit the highlights on this. But as far as where to begin and how to initiate setting that up, it can be started from any endpoint. I've had it started from the transplant team initiating it with the primary team, and I've also had the primary team ask the transplant team to sit down on it. And it's typically a nurse coordinator that makes those initial contacts and reaches out to the other team to set up those communications. You'll have to plan in advance for these sorts of things, because obviously there's a lot of people that you try to orchestrate and get into the same space. But if you can get the right people on board, specifically a care coordinator and the primary provider who is taking care of the patient at the transplant center, and then you'll want to have the person on board who's going to be taking over their care at the primary care setting. And then either setting that up in a conference call and a phone call, or if you can get a video set up, that's great too. But it's really just a matter of starting out the conversations with one another as far as what they have for available times and days, and then narrowing down on that. Once you have that day and time established, setting out invites just like we did for this kind of a meeting, and then having the transplant team start from the beginning and really just go through the patient's history. And the way I've seen this is honestly very similar to how a medical student presents a patient. They really start from top to bottom, going through systems of where they've been and how far they've come, where they're currently at, if this, then that scenarios, giving out contact information, asking those questions about, what if this lab value comes up to this? What should we do? Who should we contact? Who's adjusting medications? Who is prescribing and refilling medications? Those are the sorts of questions that you'd want to have on your list to clarify with one another when you set these meetings up, amongst many other things. But if I can get your email on this one, I can even send you some more information in email.
Yeah, and just to transition to that as well. If there's any people that want to reach out to Sarah or to the Histocytosis Association or to Lizette,